right, everyone, welcome back for this special session of Joint School Live, where we today will be discussing anaesthetics and especially topics around the anaesthetic considerations when having a joint replacement on the same day. So a day case joint replacement, or sometimes called an outpatient joint replacement. And with me today, I have Drs Pieretti and Thayaparan. Thank you so much for joining us.
Hello, hi.
Hi.
I'm Dr. Pieretti.
Yeah.
And Thayaparan.
Fantastic. So before we sort of dive in and go through some of the questions, can you tell us a little bit about yourselves and your sort of day-to-day work, particularly in terms of day case joint replacement?
Yeah. So as I said, I'm one of the anesthetic consultants here at Westminster. I'm actually the service director right now. I'm one of the anesthetic with interest in orthopedics. So there are three of us. We are usually doing joint replacement. This is our day-to-day cases. And now we are actually focalizing in doing this same-day discharge replacement.
Yeah, super. And yeah.
Do you want to say something?
Hi, I'm an anesthetic consultant as well, same as Dr. Pieretti, orthopedic. I subspecialize in orthopedics and trauma. So we have started this project as one day initially, which was successful. Now we are moving on to day case hip replacement.
Super. And as you can tell, we have a very authentic hospital ambience. Beeps and people may be coming through the door, but you know, here we are, and we'll be going through just some of the general points around having an anesthetic for a joint replacement. But what are the sort of special considerations in terms of when you're aiming to go home on the same day? Before we dive in, just a few points perhaps about kind of the general themes to help us define and navigate what is the difference between a general anesthetic, regional anesthetic, spinal anesthetic, and what's typically used for a day case joint replacement.
Okay. So, as you said, there are a lot of different kind of anesthetic that can be used for this particular surgery. We have general anesthetic, we have regional anesthetic, of which what we particularly use is a spinal anesthetic in this case. The reason between choosing from one or the other is multifactorial. In part is the kind of surgery that we're doing. So limb surgery is well covered by a spinal anesthetic without the need of a general anesthetic. But also it depends on the patient that we have in front of us. So we do usually an assessment on the patient and on the surgery that they need to have. The big difference between a general anesthetic and a regional anesthetic, obviously, general anesthetic, what people normally say to is, I'm going to sleep and not be aware of the surgery. Spinal anesthetic is a type of regional anesthetic in which some local anesthetic is injected very close to the nerve near your spine, and that will put to sleep or make unsensible just the lower part of your body, but with touching the upper part of your body. So it's not touching your breathing, it's not touching your heartbeat, it's not touching your blood pressure, it's not touching your mind particularly. For this particular setting of the day case hip replacement, we tend to suggest to have a spinal anesthetic because there are few advantages with respect to general anesthetic. The major one is better to control the pain post-op. So that allows you to do physiotherapy quicker and making the discharge process faster. And in this case, what we need is to have a patient ready to go home by evening. Okay. Yeah. The other advantage is that because they're all kind of related, because there is less pain during the first few hours, there is less need to add opioid. That is a particular medication, stronger medication for the control the pain. in a systemic way, so taken orally or taken through a vein injection. And obviously helps the patient to be more awake and more reactive, so is fastening all the post-op process. That doesn't mean that general anesthetic cannot be done, because in base of the patient, we can offer a general anesthetic, but we tend to do the day case all in spinal anesthetic if it's possible.
Okay. And so that's interesting. I guess it makes sense that it's all about trying to help people to get up and going as soon as possible and to control the pain so that they can get moving and hopefully then get home soon after their operation on the same day. But it's interesting that you say that the pain is actually less, or that the pain control is better with a spinal as opposed to having a general.
Mm-hmm. Yeah, but so in this is real as a short term. So it's different in pain control in an immediate post-op. But if we then go to see 2 days or 3 days, it makes no difference in between the two. But this is why we're trying to use this kind of anesthetic for this quick, discharge process.
Yeah. Okay.
The first few hours that make a big difference.
And I'm sure many people who are getting ready for an operation, and even those who are planning to have a day case joint replacement. Here we go. That's that authentic hospital ambience again. But well, we might hear some banging in a bit. So many people, I'm sure, will be advised to still have an empty stomach.
Yeah.
Can you tell us a little bit about why that is?
Yes. So I would call it the starving process is going to be the same anyway. So the general rules is that we suggest the patient to not have anything to eat for 6 hours before coming to hospital, and solid food, and not having anything to drink for the 2 hours before surgery. When they come to the hospital, they will be offered some sip of clear fluid, that means water. But the reason is that, first of all, we cannot exclude that you're not going to have a general anesthetic. That's the first thing. Second, even with the spinal anesthetic, it's always safer to have an empty stomach, because you may have some side effect that we can then discuss later, maybe, that maybe make you feel a little bit nauseous. And then obviously, if you have a full stomach, being nauseous is going to be dangerous. Okay. The main things that we always say that is the starvation process needs to be there anyway, just to make sure that if we have to switch to a general anesthetic, we're going to still be able to go on with the surgery.
Mm-hmm. Okay. Yeah. So it's sorry.
And also the other things is because we will discuss also this, we will offer sedation to patients. So they're not going to be necessarily completely awake during the surgery. When you have a sedation, you still need to have the same precaution that if you have a general anesthetic.
Yeah. Okay. So the reasons for having an empty stomach are kind of, in a way, similar for when having a full general, so to speak, and being fully
exactly.
And that's because to keep the option of having a general if that becomes necessary for whatever reason. And if you're having a sedation, that kind of the same rules apply. And that even if you're having just a spinal, it's still safer and better to just have an empty stomach.
Yeah. Okay. Yeah. The risk of having a full stomach when you have a general anesthetic in a general way, or any kind of anesthetic, is that when we give medication to put you to sleep, or also just to relax you with a sedation, you can lose a little bit of the reflex. So the protection of the airway during the reflex of swallowing. Yeah. And then if you have an empty stomach, full stomach, what will happen is that you may have a regurgitation of the food that then fall down in your lungs and give you pneumonia. So we want to avoid all these factors.
Absolutely. Well, so while we're then on the topic of sort of the unpleasant things that we want to avoid, what are the risks and the possible side effects to consider when having from the anesthetic point of view?
Yeah. So if we're talking about having a spinal anesthetic, okay, that's what we usually offer in this situation. there are some things that are considered absolutely normal for us, but that the patient will think that is very strange. So I usually say these things, express these things as a side effect, but it's actually what we actually want the anesthetic to do. Okay. But it's very strange when you are the one having it. So the first thing is, obviously, you will not be able to move your legs. Okay, that is the main point of the spinal anesthetic. So you will not be able to move your legs for few hours, even longer than the surgery. So the spinal anesthetic usually lasts a couple of hours and then slowly wean off. The other is a very weird sensation, I would say, because the touching sensation, so the feeling of touching on your legs is still there. So you may feel touching, but you're not going to be able to move and you're not going to be able to feel any pain. Okay. Just to make these things clear immediately, we tested the block before. So the surgeon will not be able to start surgery before we are happy that the block is working. Okay. And the testing process is very easy. We use a very cold spray. We spray on your arm, so you will feel both the sensation, the touching sensation of the spray and the cold sensation of the spray. Then we spray the same things on the legs. And what will happen is that the sensation is different. You feel the touching sensation of the spray, but there is no temperature at all. So you don't feel any cold sensation at all. Okay. If you don't feel cold, you're not going to feel any pain.
Right. Okay.
The nerves which carry the cool sensation carry the pain as well. So they are numb.
Okay, so that
anesthetized completely.
Okay, so that's
pain at all.
Yeah.
So testing for the sensation of being able to feel cold, you can then test the pain pathway by that.
Exactly. It's exactly the same pathway. So when the cold is not transmitted, the pain sensation will not be transmitted.
Okay, interesting. And so that's quite reassuring, and to have that as a bit of a test before surgery.
Yeah, no, definitely. And we also usually ask the patient to try to move the legs, to lift the legs up. A little bit of a movement can still be there, but usually what the patient say to us is everything is very heavy. I cannot move anything. Okay.
Yes.
The other reassurance things that we can say to patient is that the anesthetic will always be with them. So during all the procedure, during all the surgery, the anesthetic will always be sitting with the patient. So if they feel something strange, they can always let us know.
Okay. And what kind of things should one perhaps let the anesthetic doctor know?
Now, for example, while the block is starting to work, that may be tingling, pins and needles sensation, warm sensation. These are all normal sensation. But I like to say to the patient that, if you feel something that you're not sure, just let me know and I will tell you what's happening.
Okay. And that's also reassuring too, that you or another anesthetic doctor will be right there throughout the whole operation, and you can just have a conversation with your anesthetist, with your anesthetic doctor throughout the operation. Unless you have loads of sedation, in which case you'd practically be asleep anyway.
Yes, more or less. The other let's say, side effect of the spinal anesthetic that I usually like the patient to be aware of is that you may feel a little bit itchy. Sometimes kind of itchiness is part of the medication that we use in the spinal anesthetic. You may not immediately, and this is something that people sometimes know, because if you look on internet, things like this, you may read somewhere that you may have a bad headache. Headache is because it's very common in pregnant ladies that get a spinal anesthetic or an epidural for delivery, but it's not so common in the spinal anesthetic for joint. Just because usually the person are not pregnant at the point, and it is the pregnancy that makes the headache way more common.
Okay, interesting. Okay.
Than the injection per se. But it can still happen. There may be some people that are more subject to headache. But this is usually something that doesn't happen immediately. It happens 24 hours after.
Okay.
So it's something to be aware of. And it's usually treated with normal medication, like paracetamol and ibuprofen. And no patient will be on a lot of pain relief post-op. So the headache usually is not a problem.
Okay.
But even if it happens, it's already covered.
Okay, so I guess it's another good reason to follow the medication plan prescribed by the team, especially in those cases after the operation when you're at home.
Yeah, definitely.
You mentioned there about epidurals, and I know that's a question that comes up quite often when we discuss the topic of spinal anesthetics and so on. And what is there a technical difference between an epidural and a spinal anesthetic?
Yeah, there are actually two different regional anesthetics. Usually, they get confused by the patient normally, because to the patient looks like the same things. We're putting a needle in their back. The difference is where we are putting the needle and which kind of needle we use. So the epidural, because is used usually when you're starting something, labor or surgery, but you don't know how long it's going to take. Labor can go on for 3 days. What will happen is that we more or less go in the same space, but we leave a catheter in there, in the epidural space. There is a very small plastic catheter that gets positioned in there, and then we can use the catheter to give medication for long time. Okay. But because you have to leave a catheter there, the needle is bigger.
Okay.
Because the catheter has to pass through it. So that's why it can give you more easily headache because the caliber of the needle is bigger. The spinal anesthetic is a one single shot injection of anesthetic. The needle is very, very thin, and that's why there is way less incident of headache.
Okay, that's interesting. And so I guess that's quite an important difference. So epidural to spinal, with the spinal, is just one shot and it's a much thinner needle. So that's also quite reassuring to know for those who might be a bit concerned about what you might hear about epidurals and so on. And even with epidurals, that may be fairly uncommon.
Yeah.
Okay. So we've touched on some of the side effects. Are there any other side effects that you would not typically discuss with people before?
So is a very, very rare side effect that we have still to say to the patient is that rarely, but we are in the range of one every 200,000. You may have some damage to the nerve going down on your legs. This 1 in 200,000 is actually a damage that can go back to normal. Okay, so it's not permanent damage. It's just a temporary damage. Usually can be felt as the sensation not coming back on everywhere. So usually, like on the feet, remain a part that it doesn't feel quite right. But as I said, this is a very rare occurrence, especially with a spinal anesthetic in which the needle is very, very small.
Okay.
So patch in their legs, wherever, small numb patch or small part of their leg. It takes sometimes a couple of weeks to come back, but normally it doesn't bother. It's very, very rare.
Yep.
Well, so that also sounds quite reassuring then, and even in itself, it's a rare event.
Yes.
Okay. So that's in terms of the side effects. Is there anything else that you would discuss with people having anesthetic as a day case?
No, the usually things that get when we're at this part of the conversation is also I'm going to be awake during the surgery. And the scary part, a lot of people are scared about the spinal anesthetic, not for the spinal anesthetic, but for the fact that they think they're going to have to be completely awake.
Yeah, absolutely.
So usually what we say is we can give a range of sedation from being completely awake, of being napping through all the surgery, so not be aware of what's happening, but still having a general anesthetic. Yeah. So that means that the good effect of being breathing by yourself and not having to take over your breathing, your blood pressure control or everything is still there. So it's still good. It's also putting the patient as ease, whatever they prefer. I have patients that want to not be able to remember anything about the surgery, so they get a deep sedation. I have patients that they want to be completely awake, and there are other things they can do for distract themselves. So what I usually say to them, if you like music, bring your iPod. The only stupid thing, but it makes a big difference. You have to have an earphone, no headphone, because then you're lying on the side, and if you have the big headphone, that is going to be not usable.
Okay, that's an important piece of advice, actually, because you don't want to bring your headphones and have made a playlist,
it needs to be,
or have a podcast or a book.
Exactly. It needs to be the earphone that can stay inside, because it's like when you're sleeping on your bed on your side, you're not going to be able to have the big, you're going to be able, but it's not comfortable.
Yeah. Okay, that's a very important point, I think, because I think distraction can also be a really helpful thing during a spinal when you're awake for a procedure.
As sedation was, you can have all the range, whatever the patient is comfortable with. They can also spend 2 hours talking with the anesthetic and have a chat with the anesthetic. That's an opportunity.
Yeah. And that conversation about the amount of sedation, is that something you will have with each patient sort of on the day?
Yes. So usually when the patient arrives to hospital, the anesthetic that is on duty that day will go to speak with them. And we usually suggest always to have a little bit of sedation, because anyway, nobody comes to theater really, relaxed and happy. There is always a little bit of agitation, and it's normal. So we usually always suggest to have just a little bit, just to relax you down. But then from then on is what the patient would like. So we usually discuss with them and say, what do you think? Do you want to just have a little bit of sedation and see how it goes? Or do you want to not be aware of anything, or anything in between? The good things also of this sedation is that we can modulate it during the surgery. So you can start with a very little sedation and then say, look, I would prefer to actually sleep now, because whatever.
The conversation is getting boring.
The conversation gets boring. The anesthetic is not funny. The music that the surgeon listens to in theater is not my favorite genre, or something like that. And we can modulate at any point. Okay. So there is no worry to start light and say, oh no, then I'm going to have to stay like this. I can ease you back to have a full nap at any point, whenever you want.
I think that's really reassuring to know that you can change your mind, and if need be, you can be topped up and drift off just a little bit.
Yeah.
And they can have their dentures in. Some of them, they don't like it.
Yeah, that's a good point.
If you have a spinal anesthetic and a little bit of sedation, you can keep your denture. You can, be able to talk.
Okay. So you mentioned before we started recording that you can even watch a movie.
Yes, so I've done it with one patient. I had my computer with me, and then we just watched some stand-up comedy on Netflix.
Fantastic. I imagine that the stand-up comedians would love to know that there are people watching their show while having a new joints put into their body.
Still having a laugh, so that's the job is working.
Fantastic. Okay, excellent. So I think we've covered some really, really good ground in terms of spinal anesthetic, some of the side effects to know about, and how it actually happens. Just so that we can really start to piece together and sort of get to know what to expect. Could you walk us through what the sort of typical steps would be on the day of the operation for someone coming in to have the surgery?
Definitely. So the patient usually come in early is usually the first one on the list, because we want to be able to use the entire day, full day. Mm-hmm. So they come to day surgery. Mm-hmm. That is the ward where there is the bed in which they will be set at the beginning. Yeah. There will be a nurse, a day surgery nurse that will ask a few questions, sure that the patient got changed in hospital gown, mm-hmm. Wristband with the name, allergy, usual question. Yeah. Then the anesthetic will come and see the patient. So whoever is on duty that day will come in, introduce themselves, discuss a little bit the medical history of the patient, mm-hmm. usual question, asking about allergy, check that the patient has been started appropriately, and then have a discussion about the anesthetic. So all these things will be rediscussed. The kind of anesthetic, what are the risks and the benefit, what kind of sedation the patient would like to have or not have. Then also the surgeon will come back and have again a chat with the patient. Usually, obviously, the patient and the surgeon know each other from the clinics. But still, if there is any last minute question, both for the surgeon and the anesthetic, that's the moment to ask. Then when the patient is ready and everything's done, the patient will be moved to theater. So usually the anesthetic nurse or ODP, that is usually the person that helps the anesthetic, is like will come, collect the patient, bring him to theater in the anesthetic room. In the anesthetic room, there will be again a check. So make sure that the patient is the patient. He knows what he's doing. Everything is fine. The patient is happy. Then the first things that we're going to do is put a small cannula, usually on the hands, on the same side on which the surgery is happening. It is for positioning of the patient. And the cannula, through the cannula, we will give some fluid, and then we will need to give some antibiotics and some medication like this. And it's also the one that is used to give sedation.
Yes.
Then as soon as everything is ready, we're going to get in position to do the spinal anesthetic. This is quite an important point because 90% of doing a quick spinal anesthetic is the position of the patient. The ODP are very good in teaching and helping on the position. Usually is sitting on the bed with the legs outside on the side of the bed. And we will ask the patient to put the chin on the chest and trying to relax the shoulder and try to take a shape like a banana shape or hanger cat. That helps creating a gap in between the bone and the spine, and that makes everything a little bit easier. Then the anesthetic will leave the anesthetic room for a second because we need to get scrubbed in a sterile way and then come back. The spinal anesthetic usually take anything between 5 minutes to 15 minutes to be done, more or less. Obviously, unless it's particularly difficult or particularly easy. So the first thing is that we will clean the back of the patient with a cold solution and put sterile drape to keep everything clean. Usually, we will give a little bit of local anesthetic on the skin and 30 seconds that this small anesthetic works. It's the same things that the dentist does in the mouth. Okay, that makes the back numb. So then the proper spinal needle is not usually even felt. You feel kind of a pushing sensation.
Okay. Yeah.
And when we inject the anesthetic, we usually say to the patient at this point, you may feel a warm sensation because it's very strange. But as soon as the anesthetic goes in, you feel a warm sensation going down your legs. And helps us to know that we are in position, definitely. Okay. But if the patient knows that it's going to happen, they're not going to think that it's something strange. And then at this point, the patient is again put back, lying flat on the bed. Here, there can be two options. Or I like to make the patient lying on the legs that need to have surgery. So with the legs that needs to have surgery down. And I always have to explain that because they say, oh, but I'm going to have surgery. How is it in the position? It's because the anesthetic for gravity goes more on the legs that needs to have surgery.
Okay. Interesting. That makes sense.
And then usually we wait anything between 5 to 10 minutes to let the anesthetic settle. And then is when we start to do the testing. So as I explained before, with the cold spray, we spray the arm. You should feel both the touching sensation and the cold sensation. And then we spray the legs. You should feel the touching sensation, but not the cold sensation. And then after that, when we're sure that the block is ready, we move the patient inside theater. At this point is when the patient cannot help anymore, like his legs will not work anymore. And so with the surgeon, we will flip them on the position. So with the legs from down to up. And at this point is when we decide, if the patient decided wanted some sedation, this is when the patient will get the sedation.
Okay.
And then as soon as everything is done, we kind of say that now we can start the surgery.
Okay, now we start the stand-up comedy show. Or
Exactly. That's when the music starts, the stand-up comedy, or the sleep, if somebody wants to have enough.
So the sedation is actually done usually inside the operating room itself or inside the theatre?
Yes. So after the spinal anesthetic is done, in part because we need the patient to be able to sit up and collaborate with us to make the spinal anesthetic as quick as possible. Mm-hmm. Usually, we want to make sure that to have the patient able to tell us if the anesthetic is actually working when we're testing. Yeah, if we give the sedation too early, then the patient will not be able to talk with us and tell us, yes, I'm feeling, not feeling. So the testing point needs to be done with the patient aware.
Okay.
After that, we can have all the sedation that we want.
Okay, fantastic. Okay, and then the operation begins. The anaesthetist, the anesthetic doctor is there, and as a patient, let them know if you actually want a bit more sedation, or if you want to have a nice conversation, or if you want to watch something else, or listen to the music or a podcast or whatever you might have brought with.
Yeah.
And then afterwards, when the operation is done, could you just quickly go over? I know it may be a bit different, but in general terms, what the next steps in terms of moving back out of the operating room or the theatre?
Yeah, so when the surgery is finished, the first movement that we do is put the patient back flat on the operational back table, bed, whatever you want to call it. And then we're going to slide the patient on his normal bed, the one that he came from the surgery. Okay. One point that is quite important here that we haven't discussed before, we usually also give a nerve block at this point to help with the post-op pain. Mm-hmm. So it is a small injection that is done at the level of the inguinal area. Uh-huh. It's under ultrasound, so at the groin level. The patient doesn't feel it because there is still the spinal anesthetic, so is completely pain-free. Okay. And is an injection of 10 to 20 ml of a solution that will keep the hip area a little bit numb for longer, but without having the motor blocker that the spinal anesthetic has. So it just keeps that area a little bit numb. Okay. And that helps reducing the painkiller that you need to take orally for the first 6 to 12 hours.
Okay, so that's like a top-up injection of painkiller, and it's done while you're still completely numb, so you won't feel that injection.
Exactly. Okay. Exactly. And it's done usually when you're already on your day surgery bed.
Okay. Yeah.
You need to go back to day surgery, so at the last minute. Then the ODP and the anesthetic will bring the patient to a recovery room. That's a middle step before going back to day surgery. In the recovery room, we do the handover to the nurse that is there. There is a 1-to-1 ratio, so there is one nurse for each patient. And usually a patient stays there for 20 minutes, maximum half an hour. And it's just to make sure that the patient is not feeling sick or is not having any particular pain or anything like this. Just because it's very close to theater, the recovery nurse can give some strong painkiller. The anesthetic can come back immediately if anything happens. And then after that 20 minutes, the patient go back to day surgery, where he was at the beginning of the journey.
Yeah. Okay.
In the same spot. Then it starts the difficult part for the patient. So not difficult, but the hard work for the patient. So they're going to probably give in another 1 hour or 2 hours for the spinal anesthetic to completely ease off. Mm-hmm. Then we will start to do physiotherapy. So in the surgery is when the physiotherapist then will come and see the patient and start to make them do some exercise, standing up, moving around, do stairs, all the stuff that needs to be done to make sure that the patient can go home safely.
Yeah.
So that is when the patient has to start to do some physical work, the gym.
Yeah. Okay.
The other things that the anesthetic will do before the patient goes home is come to review the patient after they've done physiotherapy. Mm-hmm. Then start to give them the first dose of the strong opioid that then is the base of the first 3 days of pain relief at home.
Okay.
Just to make sure that the patient is tolerating it well. Because not the patient arrived to hospital without having ever had an opioid before. So don't send them home without even tried. So the first dose of opioid is given at home. Is given in the hospital, just to make sure that everything is fine. And then, so like this, we are sure that then when they take it at home, everything is going to be okay.
Okay, great. I think that's that paints a very clear picture of the road to expect from the anesthetic point of view, in terms of how the preparation kind of comes together before a surgery and kind of just moving out of it and on towards the early days of recovery at home. Of course, I'll just highlight to everyone watching this that of course there may well be differences from person to person and doctor to doctor, department to department, hospital to hospital. But in general terms, I think this has been a really, really useful overview of the anesthetic part of having a day case hip replacement. I think we've covered quite a lot of ground. Is there anything else you'd want to add before we sort of sign off for this session?
No, I think we've done quite a full job.
I think, if we may say so ourselves, I think we've covered quite a lot of good ground, and I think hopefully this will serve as quite a good reference point for the conversations that, of course, everyone will be having with their anesthetic doctors on the day anyway, and in pre-assessment and after the operation. Fantastic. Well, thank you so much for joining us, and thank you everyone for watching this. All the best with your procedure and your onward recovery. As ever, let us know what you think about this video. If it sparked any questions or ideas, let us know, and know that your healthcare team will be there for you. They'll have a plan for you, and if you have any questions about your care, ask your healthcare team, and they'll know what to do. But super. So thanks so much, everyone, and wish everyone all the best.
Bye. Good luck.
Super.